Hello, everyone. Thank you for joining me for this review of arrhythmias with Dr. Logan Funk, sponsored by Hills. We're so glad we caught up with Dr. Funk. He had just finished his cardiology residency at the University of Missouri and was actually in the middle of packing up for a big move when we talked to him, but he generously agreed to share his knowledge and his time with us anyway. And let me tell you, if you have cardiology questions, Dr. Funk has the answers. He is brilliant and had all of the answers to all of my burning cardiology questions at his fingertips. Dr. Funk grew up in northeastern Wisconsin and attended the University of Wisconsin-Madison for the duration of his undergraduate and veterinary medical studies. He completed an emergency and critical care internship in Milwaukee, Wisconsin, as well as a specialty cardiology internship in Los Angeles, California. In July of 2019, Dr. Funk began a cardiology residency at the University of Missouri. He completed the program in July of 2022 and has fulfilled all requirements for diplomate status within the American College of Veterinary Internal Medicine Specialty of Cardiology. If you enjoy this episode, you can find more CE from Dr. Funk and others on the Hills website, hillsnorthamerica.com. All right, I'm joined today by Dr. Logan Funk, who just completed his cardiology residency at the University of Missouri. Congratulations, Dr. Funk. Thank you so much for joining me.
Oh, thank you so much, Dr. Fleming. How are you doing?
I'm good. It's so nice to talk to you today. And, we did a little prep work here and spoke about arrhythmias, and I called you an encyclopedia of knowledge. So I look so forward to bringing that to our listeners.
Oh, that's exceptionally generous of you, and I will do my best.
I have full confidence in you. So starting with the basics for people like myself, when we see or hear an arrhythmia, what are some of the considerations that we should keep in mind to help us determine the diagnosis and determine how to act in that situation? Namely, how do I stop the blind panic when I'm like, oh no, what's going on here?
Yeah, that's a great question, because I think especially when we hear a highly irregular or very slow heart rhythm in a patient that's presenting with overt clinical signs, it is easy to start to jump into that action mode where we're trying to decide what we need to be doing immediately. And really the first step is to do everything we can to make a rhythm diagnosis. That's going to dictate our plan of action. And we can't do that without an electrocardiogram. So even if a rhythm sounds extraordinarily irregular and fast, I can't determine if that's atrial fibrillation or if that's paroxysmal ventricular tachycardia until I actually look at a tracing. So first step is just to place those lead electrodes and get a tracing, and whether we're using just an ECG monitor or a multimodal integrated monitor like in the anesthetic setting or the emergency room, we can get the vast majority of what we need from a simple lead 2 tracing. So that really requires that we only place 3 electrodes on our patient, and then we can get our bipolar leads 1, 2, and 3, and we always use lead 2 for reference. Now, again, if we have a rhythm that's very irregular, there are a lot of different things showing up on our tracing, it can be very easy for any of us to get overwhelmed. So I always break things down into the basic constituent parts to begin with and ask myself questions like, what is the underlying rate? Is the machine giving me a rate that matches with what I'm hearing on auscultation? If I have a printout, I can quickly calculate an average heart rate for things like atrial fibrillation, where the average is more meaningful than just a strict coupling interval. So using a simple tool like a standard Bic pen with the cap on, if I know my paper speed is 25 millimeters per second, I can use that Bic pen, count the number of QRS complexes that occur over the course of that Bic pen. And then the mnemonic we use is pen times 10, and that tells me the number of beats per minute. If it's a 50 millimeter per second tracing speed, then I just do it by 20. So since the paper speed is double, we double the number we're multiplying by. So that's a general area to start. How rapid is our rhythm, or how slow is our rhythm? Is it regular or irregular? Do I see P waves on the tracing? If I do, is there a consistent relationship between the P waves and the QRS complexes? And then a big question that we'll want to ask when we're determining how clinically significant or how scary an arrhythmia is are the QRS complexes narrow and do they look similar to our sinus complexes, or are we seeing wide and bizarre looking complexes? A more narrow complex tells us that likely the rhythm is originating in the supraventricular area of the heart and less likely to be life-threatening versus wide, bizarre-looking complexes, especially with a tachyarrhythmia, are more likely to be coming from the ventricles and associated with the risk of sudden death. Now, we can also see wide, bizarre-looking complexes that would be associated with a slow heart rhythm, and those would be ventricular escape rhythms. So we would take a different course of action with those rather than something like ventricular tachyarrhythmia or ventricular tachycardia. And then we can have rare instances where there is a wide, bizarre-looking rhythm that still comes from above the AV node, so a supraventricular tachycardia. And that would be a scenario where we have either a sinus or supraventricular rhythm, ectopic rhythm that is being conducted with a bundle branch block. And so those will respond to medication differently than something like ventricular tachycardia.
So just to make sure I'm hearing you correctly, when we hear that arrhythmia or see it under anesthesia, something like that, we're looking for rate. Is there a P for every QRS and a QRS for every P wave? And is it wide and bizarre, or is it narrow and more sinus looking, to kind of help determine how panicked we should be in that moment?
Precisely. Yeah, exactly. And certainly there may be times with a patient that's presenting in shock or after an anesthetic episode where maybe we encountered significant bleeding or something like that, where we have a true sinus tachycardia that's occurring at a rate of 200 or 250 beats per minute. And I think sometimes there is a default to be worried about that number. And while we do want to intervene appropriately to bring that number down, it wouldn't be a scenario if it's a sinus tachycardia where we start things like calcium channel blockers or beta blockers. So if I'm convinced that I just have a sinus tachycardia, first steps will be to make sure that we are appropriately analgesing a patient, make sure that we have appropriate volume status. If I have a narrow complex tachycardia that's 250, 300 beats per minute, and I'm not seeing P waves because they're buried in the preceding QRS complex, that's when we'll start to think about a supraventricular tachycardia and then ask the question, in ectopic supraventricular tachycardia rather, and ask the question, do we need to intervene with pharmacotherapy? And part of that equation will be, is the patient hemodynamically affected? Do they have a change in their blood pressure? Are they exhibiting clinical signs?
I'm so glad that we're having this talk because, there's so many considerations, there's so many variables to keep in mind. And I'm sure all of you listening out there see what I mean about just the amount of knowledge that Dr. Funk brings to the table here as far as our considerations on how to respond to this. And you're reminding me of rhythms that we don't see as commonly in private practice. So I'll be honest, sometimes I forget that they're out there, like the bundle branch blocks and, the supraventricular tachycardias and some of the considerations that come with that. Fortunately, we don't see a ton of shock patients, at least speaking for myself, although with how busy veterinary medicine is, we're seeing more and more of this in private practice and less ability to refer just because of the patient load. So thank you for giving us such a good review and reminding us of all these basic considerations that we need to keep in mind for arrhythmias that sometimes just get lost in the shuffle.
Oh yeah, and I'm just speaking from direct experience with our ER and our surgery services. So reaching back to the sinus tachycardias, that might be a little bit more rapid. Part of why we always initially try to rule out or exclude is a rapid rhythm sinus in origin is because if it is, I don't want to necessarily give that patient a beta blocker or a calcium channel blocker until I've made sure that their volume status is appropriate and that they're analgesed adequately, so that we can really say it's an inappropriate sinus tachycardia. Because if it's appropriate for that patient, by blocking that physiologic response, we could actually make things worse. So again, just a very common scenario for us to be thinking about in our cardiology services. Have we addressed those things first if we have a rapid supraventricular narrow complex rhythm where we can see CP waves? And sometimes those can be ectopic too, especially when the rates are very high, and then we need to take additional steps.
Sure, certainly with our cardiac output being partially dependent on rate, if we don't have the rest of our components in line and we drop that heart rate, then if they weren't hemodynamically affected, then they will be.
Yes, yeah, exactly.
What are some immediate considerations we should keep in mind?
If a patient is presenting and they are completely stable on physical exam and we incidentally detect an arrhythmia, let's say, for example, an 8-year-old boxer dog that's ostensibly healthy, and we hear a short paroxysm of a rapid tachycardia, my top suspicion will be that that dog has arrhythmogenic right ventricular cardiomyopathy. But that dog is not exhibiting clinical signs, doesn't apparently seem to be hemodynamically affected in that instant. So while it's important for us to investigate and work that up and determine, does the dog need chronic therapy, that's not a scenario where we would be just based on hearing that short run of a tachycardia, admitting that patient to a hospital and going into panic necessarily. Conversely, if we have a patient that's coming in to the hospital in hemodynamic collapse, is lateral recumbent, and we hear a really rapid rhythm, put on our ECG leads and on our lead 2 tracing, we have a wide complex tachycardia at a fixed rate of 250 beats per minute or 300 beats per minute, my initial differential until proven otherwise is going to be ventricular tachycardia. So I'm going to be reaching immediately for a dose of lidocaine to try to break that rhythm, because that is a rhythm that could devolve into something electrically more unstable, like ventricular fibrillation, which of course is an arrest rhythm. So we would drop a 2 milligram per kilogram dose of lidocaine for that patient, administer it, and if we don't break the rhythm, I would give another dose, and we can go up to 8 mg per kg sequentially. So in repeated 2 mg per kg doses for that patient before we need to take a break. And if I successfully convert that dog to a sinus rhythm after giving a bolus of lidocaine, then I'm going to be thinking about how I'm going to keep them in sinus rhythm. So likely starting them on a lidocaine CRI for monitoring in the hospital before we convert to oral therapy, with sotalol oftentimes being a first line for us. If they don't convert, even after giving several sequential doses of lidocaine, on our end for the cardiology department, there might be other drugs that we'll think about or select if we're really convinced that this is a ventricular tachycardia. The other thing I might start to ask myself is, could this be a wide complex tachycardia that's actually supraventricular in origin, but conducted with a bundle branch block? We do a couple of times a year, I'll say, encounter dogs with atrial fibrillation and a bundle branch block, whether it's left or right. And those can be really tricky cases when the AFib is occurring at a rate of 300 beats per minute. The irregularity of the rhythm is less easy to discern on an ECG, but sometimes we can do something like a vagal maneuver, applying ocular pressure or carotid massage to slow down or limit conduction through the AV node, create more gaps between QRS complexes, and that can unmask some of that irregularity that then tells us, oh, this is indeed atrial fibrillation with a bundle branch block, and we need to be thinking about a calcium channel blocker to slow down the rate rather than lidocaine.
I love that you brought up lidocaine and vagal maneuver. Let's dive into those a little bit more. Remind us our techniques as far as, ocular pressure, carotid massage to slow that down. And then also, if we can talk even a little bit more about lidocaine, you said 2 mg per kg. We can give it in sequential doses up to 8 mg per kg. How are we giving that? Is that a slow push? Is that something we need to do even slower? Can we rapidly bolus that? And how long in between boluses? Like, what are some of those things we need to make sure we're keeping in mind with lidocaine?
Sure. It should be a gradual push. It doesn't need to be excruciatingly slow, but just a gradual push. And then I usually wait a minute or two after bolusing to see if there is any effect on the rhythm. So I'm not necessarily drawing up the second dose immediately. I want to give them a chance to respond, but we don't have to wait an extraordinarily long time if we're not really seeing any change in something like a ventricular tachycardia. The dose indeed is 2 mg per kg for dogs IV, and we can repeat that up to 4 times for a total dose of 8 mg per kg. Lidocaine is a medication that's rapidly metabolized. So if you give 8 mg per kg in short order, and the dog ultimately converts, but then reverts back to having ventricular tachycardia 2 hours later, we can repeat that sequence of bolusing again. That lidocaine should, by and large, be metabolized at that point. And if we are going up to those 8 mg per kg total doses in short order, I would be cognizant of signs related to GI upset and certainly neurologic signs. So watching for those things. Sometimes when we put our patients on a high rate lidocaine infusion, we preemptively give them meropitant because some of them will become a bit nauseous. Although if that's the case, then I also generally want to titrate them back on their dose if I can. We're always giving it intravenously. In cats, we also give it intravenously, but our doses are significantly lower. So 0.25 to 0.5 mg per kg. If we give a cat a 2 mg per kg bolus, then we have a much greater risk of neurologic toxicity.
I know that was a super long question. I added like 5 different pieces to it. I was like, can you talk about all these things? Can we circle back around to the vagal maneuvers, and how long do we give it with ocular pressure, carotid massage, or what are some of the things we need to keep in mind with that one?
Yeah, so if we're doing a vagal maneuver to either try to break a supraventricular tachycardia, so in some instances, we can actually induce an instance of second degree AV block for a patient that's having supraventricular tachycardia, and that gives them a chance to maybe revert back to sinus rhythm, or it just blocks the supraventricular tachycardia in a way that lets us get a better idea of what exactly is going on from a diagnostic side as well. We can either induce that type of block, or, as I said before, in cases of atrial fibrillation, especially when there's a bundle branch block and we're trying to figure out what is the true nature of this wide complex tachycardia, by decreasing the number of impulses that are traversing the AV node in a patient with that atrial fibrillation, we start to unmask more of the irregularity in the rhythm and see that it is indeed something that's coming from above the AV node and relying on the AV node to conduct to the ventricles, and is just doing that with a block rather than a rhythm that's truly coming from the ventricles as the point of origin. The way that we do a vagal maneuver in a dog or a cat would be to apply gentle but firm pressure either to the eyes or the carotid region, or both simultaneously. And not all patients will respond positively, but I'm generally going to do that for 30 seconds or more to try to get a sense of if I can break the rhythm or not, or at least slow down or decrease the amount of AV nodal conduction to slow down the overall ventricular response rate, like in atrial fibrillation.
Awesome. Thank you so much for reviewing all of that, because it's one of those where, like, pressure on the eyes will slow the heart rate, but exactly what you're looking for and when to use those types of techniques, again, I think is one of those things that, at least for me, gets a little bit lost. So I really appreciate the review.
Oh, yeah. And it's something that we have to remind ourselves sometimes too, but when it does work, it's very rewarding and exciting, actually. So, yeah.
Absolutely. So let's talk about some of these common or more common arrhythmias that we might see in practice. For example, we've kind of touched on an AV block a couple of times. Can you talk to us about what those arrhythmias would look like and what sort of actions we should take when we see them?
Sure. Yeah. So moving away from the tachyarrhythmias, which I think would be kind of the most initial panic types of rhythms to see and sort out. If we have a dog that's coming in with an unexpectedly low heart rate, let's say it's a 12-year-old Labrador that is wagging their tail in the hospital, panting pretty hard, but their heart rate is only 50 beats per minute. When we apply an ECG, we might find that they have atrioventricular block. And there are, of course, 3 different levels or degrees of AV block. First degree AV block just simply being a prolongation of time for conduction across the AV node, and that's manifest on the ECG as just a long PR interval. But what we worry about clinically and where we need to intervene really would be with high-grade second-degree AV block. So in that scenario, we would see some sinus beats conducted with an expected or maybe prolonged PR interval, but there does seem to be times when a P wave is followed in kind of normal succession by a QRS complex that's narrow. But other instances in which we have a P wave that is not followed by a QRS complex, it may either be followed by multiple P waves in a row, or it might just be a single P wave and then the next P wave conducts to a QRS, or we might have several P waves in a row with an intervening wide bizarre QRS complex, and that would be a ventricular escape beat. So in dogs that are having high-grade second-degree AV block, or cats for that matter, we would see multiple P waves in a row before eventually getting back to a sinus rhythm that's being conducted across the AV node. And those dogs could absolutely experience syncope because they're not able to physiologically increase their heart rate in response to activity or the demands of exercise. The other scenario, of course, would be third-degree AV block or complete AV dissociation, where none of the signals that are being generated by the sinus node are able to conduct to the ventricles. And so the subsidiary pacemakers in the ventricles have to take over ventricular pacing for themselves. Otherwise, we would have ventricular asystole. So in that scenario, we would see two distinct rhythms on our ECG tracing. We would have likely a sinus rhythm that may or may not be regular. There can still be vagal influence that would create some difference in the P to P interval over time, but would be at likely an expected rate of between 80 and 160 for a dog for the sinus rate, the P to P rate. And then we would have a separate rhythm that would be the ventricular escape rhythm. So that would be wide bizarre complexes happening at a very regular interval between 30 and 60 beats per minute. If we do diagnose either of those rhythms, those patients are at risk of sudden death. Maybe not in that moment, but there is a risk that their subsidiary pacemakers can fail at some point and they can develop ventricular asystole. Or what oftentimes seems to happen is their ventricular rate slows down until eventually they develop multiform ventricular tachycardia or torsades. And then ventricular fibrillation. So the recommendation is to always refer those patients as expeditiously as possible to a facility that has a cardiologist that would be capable of placing a pacemaker to take over the heart rhythm for that patient.
And we've talked earlier about identifying arrhythmias in tachy versus brady. This, of course, being a bradyarrhythmia. Despite the fact that we may periodically be seeing these wide and bizarre complexes, this is one scenario where we would want to stay far, far away from the lidocaine.
Yes. And the other thing that can happen in patients with high-grade second-degree or third-degree AV block is we may intermittently have an accelerated idioventricular rhythm. So that would be a wide, complex rhythm that happens at a somewhat faster rate, 120, maybe up to 160 beats per minute, but it's not ventricular tachycardia, and that won't respond to lidocaine. The fortunate thing for the patient in that scenario is the AIVR, accelerated idioventricular rhythm, is not a life-threatening arrhythmia, and it may be giving them better cardiac output than their basal escape rhythm otherwise would be. The fear with giving lidocaine or beta blockers or calcium channel blockers to a patient that's having very slow, wide, bizarre complexes from a ventricular escape rhythm is that we could terminate or disrupt that escape rhythm and cause them to have, again, ventricular asystole. So until we have an option for artificial pacing, we do try to stay away from those things. And the most important thing is to get them in a facility where they can have 24-hour ECG monitoring until a plan can be formulated to get a pacemaker. And then sometimes that's more urgent than others. So there may be an option for a dog with a escape rate of 60 beats per minute. That's very reliable to wait and get a pacemaker the next day. We know that complication rates are lower when we do a procedure of that type with all of our normal staffing during typical daytime hours versus if we do it after hours with kind of more of a skeleton crew, even though everybody, of course, is very skilled in what they're doing, the complication rates just go up. But there are other times where we don't have the option and we have to intervene more urgently. But that would be, again, a scenario where pharmacotherapy really isn't going to help us, and we just need to get them to a facility or a hospital where somebody can place the artificial pacemaker and take over the pacing function.
Let's talk about a couple other arrhythmias. One that I have listed here is a ventricular escape rhythm, which I feel like you talked about a good bit with the AV block. Anything else you want to say about ventricular escape rhythm?
The other major scenario where we might encounter a ventricular escape rhythm, rather than just maybe an intermittent occurrence in a dog that's sound asleep. So in general practice or ER, that's probably not something we'll see, but we see it commonly on our Holter monitors or our 24-hour telemetry in hospital. But the other scenario where you might have a dog or a cat come in that is symptomatic for a bradyarrhythmia, and you just see a ventricular escape rhythm, would be atrial standstill. So in that setting, we would not see any P waves whatsoever in our ECG. So again, with third degree AV block, and I find that sometimes this becomes a point of confusion, maybe a little bit, and it's for the purposes of how we intervene, it maybe sounds a little bit arbitrary, but with third degree AV block, we still see P waves marching along across our tracing, and they're interrupted by these wide bizarre complexes that represent the escape rhythm. In atrial standstill, there are no P waves anywhere on the tracing ever. It's just the wide bizarre complexes that represent the ventricular escape rhythm. In dogs in particular, there is a phenomenon called atriocardiomyopathy, where their atrial cardiomyocytes are replaced by fibrous tissue and they lose the ability to conduct impulses in their atria. So that would be a potential cause of atrial standstill. But we also always consider causes of transient atrial standstill. And the most notable of those would be hyperkalemia. So something that we can quickly screen for in a clinical setting. And in cats, if we do have a hyperkalemia, then of course we're asking, is there a potential that this patient has, for example, a urinary obstruction? In dogs, we might be thinking more about Addison's disease. But when we correct the electrolyte imbalance, we should also restore a normal sinus rhythm in that patient. So if a dog has a totally normal potassium, a normal electrolyte panel, then we might deviate more towards thinking about atrial cardiomyopathy and say, this dog needs to get a pacemaker. But of course, we don't want to put a pacemaker in a dog or a cat if we can simply correct an electrolyte imbalance and get them back to feeling normal. If a dog or cat does present with clinical signs of a bradyarrhythmia and ultimately on an ECG you diagnose second or third degree AV block, it is important to get a detailed history from the owner, including potential toxin exposures. Now, the team who goes on to place the pacemaker should be asking all of the same questions, but really finding out, is there any possibility that the animal would have ingested a plant like lily of the valley, oleander, foxglove? Does anybody in the household take heart medications, beta blockers, calcium channel blockers that an animal could have gained access to? Because again, we might need to think about temporarily pacing that patient or starting interventions to reverse a drug toxicity if one occurred. But that patient might not require a permanent pacemaker if they were exposed to one of those agents. And we have had a patient at our hospital. It was before my time in residency here, but a dog that was a repeat offender with ingesting, I believe it was oleander that was in the client's backyard, and so would present in third degree AV block after having ingested that plant.
No kidding. No kidding. Good history questions to follow up on. Refreshing our cardiology knowledge here, and then also back to toxicology and toxic plants, because, again, just not something you see all the time. And so sometimes, like here in Florida, we think like sago palms. All right, we know what sago palms do. Many of us know what lilies do. But for me, of course, I remember oleander is toxic, but having to remember like what exactly it does. So all excellent history questions to bring back to top of mind and make sure we're aware of if we are seeing these arrhythmias in practice.
Definitely. Yeah. And like I said, too, hopefully the cardiology team that you refer the patient onto is also asking those same questions. But it can really be important to determine what is the best course of intervention for that patient, obviously.
Is there a predisposing factor for this atrial cardiomyopathy? Is there something that causes it to happen, or is it just these unlucky pups?
So it is something that has been identified more frequently in specific breeds. We've had other patients that are outside of those breeds where we have diagnosed atrial standstill and needed to place pacemakers. So it is something that could affect potentially any dog, but there are definitely patients that might be more predisposed. So English Springer Spaniels and Old English Sheepdogs have been reported.
Okay, interesting. Couple other arrhythmias I want to make sure that we talk about. What about a wandering pacemaker?
So a wandering pacemaker is something that would be represented by fluctuations in the amplitude of the P wave on an ECG tracing. So the P wave will simply be shorter and taller at variable intervals, and it's really determined by prevailing autonomic tone. So we think of vagal tone being the major determinant of cardiac function and rhythm at rest in dogs. And it doesn't really have any major significance other than to tell us that the patient has high resting vagal tone. So if we're looking at depolarization of the atrial myocardium, we would be able to explain the wandering atrial pacemaker by the path of conduction that an impulse takes out of the sinoatrial node, but it's not something that we need to worry about or intervene. So if we are seeing P waves, but sometimes they're harder to see than others, or the P waves getting really short, that would again be a wandering atrial pacemaker, but not something that would make me panicked or concerned by any means.
Okay, thank you for reviewing that. I remember seeing a couple of those when I was in vet school. And then as we were kind of doing our prep work for this podcast, I was like, what do those look like again?
Yeah, absolutely.
What about sick sinus syndrome?
Sick sinus syndrome, as the name implies, really describes the occurrence of clinical signs in dogs that have sinoatrial node dysfunction. So if we have a patient and we perform an ECG and happen to see maybe some signifiers of sinoatrial node dysfunction, but that patient is clinically unaffected, then we'll probably say that they have sinus node dysfunction, or maybe chronotropic insufficiency would be the relevant terms. But if a dog like an older Westie dog is coming in and they're having syncopal episodes, and we see on an ECG tracing that they're having unexpected periods of sinus pause or sinus arrest, then we'll be suspicious that they have sick sinus syndrome. At times, it can be a little bit challenging to confirm definitively. We use things like a Holter monitor and atropine response test to help us do that. So, for example, if we had an index of suspicion in an individual patient, we would administer atropine either IV or by another parenteral route, and observe an ECG tracing after giving that drug. And if their sinus rate increases appropriately and the rhythm becomes more regular, then it's less likely that they have sick sinus syndrome. If we continue to see a slow heart rate of 100 beats per minute or less, just for example, those aren't strict numbers, but and their rhythm stays irregular with basically no change after administering the atropine, then that would help us to say that this patient likely has sick sinus syndrome as a cause for their clinical signs, and they probably need to have a pacemaker placed. If a dog is presenting for syncopal episodes and is having an unexpectedly slow heart rhythm in the clinic, especially for their demeanor and an irregular rhythm, and when you do your ECG, it just looks like a sinus arrhythmia, that I think would warrant referral to a cardiologist to look into the possibility of sick sinus syndrome. So you've already excluded second or third degree AV block by doing that ECG, or at least they're not having frequent high-grade second-degree AV block if you're not seeing any evidence of that on your tracing. But the pauses in their sinus rhythm might be enough, especially if they're happening at unexpected intervals, to cause the patient to have their clinical signs when they try to exercise or get excited or something like that.
Clinical signs being exercise intolerance, syncope, that type of thing?
Yes, absolutely.
Okay. Any tips? I'm just thinking, I'm trying to picture myself in practice looking at this patient, and I hear an abnormally slow heart rate. I put an ECG on and I see what looks like a slow sinus arrhythmia. At that point, does it make sense to refer? Am I really kind of correlating that with clinical signs? I'd hate to send you guys a bunch of patients that just have a sinus arrhythmia. Is there anything to kind of cue me in as far as like this would be the sick sinus patient and this truly is a sinus arrhythmia?
Yeah. So if there is some cyclicity to the arrhythmia, for example, if the sinus rate seems to speed up as the patient's breathing in and then slow down as they breathe out with a maximum pause at end expiration, then that would fit with a respiratory sinus arrhythmia. And that patient might just have high resting vagal tone. If the pauses in the rhythm seem very unexpected, so let's say for a sequence of 4 or 5 beats, we have a pretty fixed regular R to R interval for our QRS complexes. And then all of a sudden there's a protracted pause, and then it kind of resumes with a fair degree of regularity, and the patient is just sitting on the table panting and looking very stressed, then that would make me think that sinus node dysfunction is certainly a possibility. The other scenario where we would want to know about sinus node dysfunction, even without the occurrence of clinical signs, would be if we have any reason to sedate or anesthetize that patient. So if we're anticipating a dental procedure, I would probably give a cardiologist a call and ask them if they're willing to look at some tracings and see if they agree. And if they say, I think that this is just a sinus arrhythmia, fine. If they're worried about sinus node dysfunction, then they might recommend referral to do something like an atropine response test, as well as a more detailed workup of the patient's cardiovascular status. Part of what we're trying to determine is if a patient has a sinus arrhythmia that's non-pathologic but simply isn't strictly a respiratory sinus arrhythmia, they should be able to respond well to atropine or glycopyrrolate when they're under anesthesia, so we can intervene if their heart rate is too slow while they're receiving an inhalant anesthetic. A patient with sinus node dysfunction may not, and so they would not be a good candidate to undergo an elective procedure. If for some reason we do need to go ahead with either a surgery, or let's say they have a dental abscess that we need to address, then we might recommend doing that with temporary pacing in place so that we can control the heart rhythm during a procedure. And so that would be done at a facility that has a cardiologist to do that.
Perfect. So like so many things, I would say everything in medicine and in veterinary medicine specifically is looking at the whole patient.
Exactly. Yeah. And there will inevitably be some gray area. And I think we've highlighted that a bit. So again, our wide complex tachycardias, the reason we use that term is because sometimes they're ventricular, sometimes they're not. Sick sinus syndrome, that we refer to that as a syndrome because it's not always immediately apparent just based on ECG characteristics right away that a patient has that sinus node dysfunction. And so we need to take additional steps. So when something isn't clear cut, that would be a great time to reach out to a specialist to have another set of eyes, take a look at an ECG tracing, hear the history of the patient, and give some collaborative input on what might be going on and what best next steps would be.
Perfect. Well, Logan, Dr. Funk, this has been fantastic. I've learned a lot just in our short conversation here. I feel like I could sit here for another hour and ask you all my cardiology questions because your answers are so thorough and really practical to go ahead and bring back to our patients and make sure that we're remembering these different arrhythmias and we're working them up correctly and referring when we need to. So thank you so much for all of this information. Are there any final thoughts you want to share with everybody?
I would just say that ECGs can be challenging, and if they do feel daunting to you, you're not alone. But as we said at the beginning of our talk, if we kind of break things down into the simplest components of the ECG, we can get a ton of information without feeling overwhelmed. And there are times even within our cardiology department where things aren't clear. So if you are feeling lost, it's never wrong to reach out to a colleague for some assistance and help, and that may include obviously a cardiologist or another specialist. And we're always very, very happy to collaborate and find the right answer for a patient.
Awesome. Well, thank you again for joining me on the podcast. This has been great.
Absolutely. It's been my pleasure.
Dr. Funk, that was awesome. Thank you so much for coming on the podcast and sharing your time and your expertise with us. I want to say a big thank you to Hills for sponsoring this episode, and of course, thank you to all of you for joining us. For more episodes like this, click on the Education tab on the Vetfolio website. As always, we'd love to hear your input on this talk, as well as ideas for topics you'd like to hear from us in the future. Feel free to reach out to me at dvm@vetfolio.com. You can also visit my Facebook page at Dr. Cassi DVM, and you can find me on LinkedIn. And remember, if one animal is better off because of you today, it's a great day.